Welcome to Roadmap to Residency, Evidence-Based Applications. And this video, we will quickly review through the transfusion reactions and graft versus host disease. So here we have a question. So a 35-year-old woman with a history of systemic lupus erythematosus presents to the emergency department with a fever, chills, and severe back pain. She received a blood transfusion for anemia secondary to SLE 3 days ago. On examination, she is febrile with tachycardia and mild jaundice. The lab studies reveal hemoglobin of 8.2 gram per deciliter, total bilirubin of 3.5 mg per deciliter, and lactate dehydrogenase of 850, which is quite high. Peripheral blood smear shows cystocytes. Which of the following is most likely diagnosis? Acute hemolytic reaction, febrile non-hemolytic transfusion reaction, delayed hemolytic reaction, transfusion-related acute lung injury, or transfusion-associated circulatory overload. So this patient presents with fever, back pain, tachycardia, and evidence of hemolysis following a recent blood transfusion. So these findings are consistent with an acute hemolytic transfusion reaction, which is most commonly due to AVO incompatibility. Also, in patients with SLE, the risk of hemolytic reactions is increased due to the presence of autoantibodies. Febrile non-hemolytic transfusion reactions typically present with fever alone and are caused by leukocyte antibodies. Delayed hemolytic transfusion reactions occur days to weeks after transfusion and are characterized by a mild to moderate decrease in hemoglobin concentration with evidence of hemolysis, whereas TRALI presents with acute respiratory distress and bilateral pulmonary infiltrates on chest radiograph, and TACO presents with dyspnea, orthopnea, and evidence of fluid overload. Now, talking about the allergic or anaphylactic reaction, the type 1 hypersensitivity reaction against plasma proteins in transfused blood. So it is generally seen in the IgA deficient individuals, okay? They are more prone. So the IgA deficient individuals should get a washed RBC. Okay, the IgA is washed out there. And it can occur within minutes, 2 to 3 hours. And the clinical feature may be urticaria, pruritus, anaphylaxis, wheezing, hypotension, respiratory arrest, and shock. So when the donor plasma proteins, including IgA, can react with the antibodies, then it can cause allergic or anaphylactic reaction. Talking about acute hemolytic reaction, which can occur during transfusion or within 24 hours after the transfusion, it is typically due to the ABU blood group incompatibility, and it causes intravascular hemolysis. The clinical features may be fever, hypotension, tachypnea, tachycardia, or flank pain. Okay. So when the donor RBC with A and B group antigens react with the host anti-A and anti-B, then acute hemolytic transfusion reaction takes place. They're talking about a febrile non-hemolytic transfusion reaction. So cytokines created by the donor WBCs accumulate during the storage of blood products. The reactions are prevented by the leukoreduction of blood products. It can occur within 1 to 6 hours, and the patient generally complains of fever, mostly fever. So the TRALI, okay, so the TRALI, there is the two-hit mechanism. So first, the neutrophils are sequestered and primed in pulmonary vasculature due to the recipient risk factor, and then the neutrophils are activated by a product in the transfused blood and release inflammatory mediators, which can cause increased capillary permeability, and ultimately the patient will have pulmonary edema. The thing is that it occurs within 6 hours of the blood transfusion. Generally, the patient to have the unit will say that the patient received a massive blood transfusion like that. If it is more than 6 hours, and on top of that, if there is circulatory overload, then that is called as TACO. Okay, not TRALI, that is TACO. Talking about the delayed hemolytic transfusion reaction, the anamnestic response to a foreign antigen on a donor RBCs or other minor blood group previously encountered by recipient. It is generally self-limited and is clinically silent. So we have one more question here. A 45-year-old woman with a history of refractory Hodgkin lymphoma undergoes an allogeneic hematopoietic stem cell transplant from an HLA-matched sibling donor. 3 weeks post-transplant, she develops fever, diffuse rash, and watery diarrhea, and significant liver dysfunction. Lab findings show pancytopenia, elevated liver enzymes, and hyperbilirubinemia. The skin biopsy reveals lymphocyte infiltration and apoptosis of epidermal cell. The patient's symptoms worsen despite broad-spectrum antibiotics and supportive care. Which of the following is the most likely diagnosis? Acute rejection, graft versus host disease, chronic rejection, primary graft failure, or engraftment syndrome. So this is a vignette of graft versus host disease. So graft versus host disease, the grafted immunocompetent T cells proliferate in the immunocompromised host and reject host cell with foreign proteins, which can cause severe organ dysfunction. The HLA mismatching increases the risk of GVST, and it is a delayed sort of type 4 hypersensitivity reaction. The patient complains of maculopapular rash, jaundice, diarrhea, hepatosplenomegaly. Usually in the bone marrow and liver transplants, it is seen, the GVST. And there is potentially beneficial in bone marrow transplant leukemia. But for the patients who are immunocompromised, we need to irradiate the blood products prior to the transfusion to prevent graft versus host disease. Thank you for watching. Keep studying hard.